Hello, and welcome to a very special segment of the Smile Now podcast where we are doing Ask the Expert. I'm joined here with Dr. Caleb Stott, my partner here at Smile Now. Dr. Stott, thanks for joining me.
I'm really excited to be able to do this, and I think it's going to be really beneficial for people that are looking to do these treatments and looking to somebody that can help them out. Okay, so next question. I am 6 months post-op, all on 4/6. I recently developed pain in a lower implant that is now going down into my chin. I do believe it's an infection. I have an appointment to go in tomorrow, and I'm doing saltwater rinses. I'm pretty miserable and very worried of implant failure. Anyone have an infection of the implant and was fine after treatment? I need some hope. Yeah. So definitely a concern, and there are instances where an implant gets infected. The bone does not attach to it, and then what the body does is it rejects it. It rejects this foreign material, and it will wrap it up in granulation tissue. Like granulation tissue will develop all the way around the implant, and then it becomes loose, and this is considered an infection, right? So the first thing to do is just get it out. If it has not fused with the bone, you want to get an implant out as soon as possible. Any kind of mobility with an implant is like a kiss of death. It's not going to get better. Antibiotics are not going to make it better. You just need to get it out, clean the site. You can bone graft the area, and then you can reuse it later, right? Mm-hmm. In this instance, this is why we like to do all on 6 instead of all on 4. If that was to happen, we have 5 other really good implants to work with. Maybe we don't even have to do a surgery if you don't want to do a surgery, or you could replace that one in fresh new bone somewhere else. That's no problem. Mm-hmm. I would say, like, how often does this happen? Not a lot, right? I think in the last 6 months, and I've probably placed like 1,500 implants in the last 6 months, I have had 2 implants that didn't make it, and none of them were like this huge infection or anything like that. It was also in people that had other issues going on, comorbidities, that like decrease the success rate of implant integration. So, and then the other thing that I would just add is, like, in literature, like 95% of implants that get placed make it. That means that 1 out of 20 in this initial surgical phase, the initial moment that you put the implant in, they're integrating with the bone, and they're becoming usable afterwards. So 1 in 20 might not make it, and that's pretty high success. And I think you and I both see much higher success than that even. So
yeah, no, I would agree, and I think I don't really have to add much there. I mean, I think one of the best points is that this is one of the reasons that even though implant failure isn't super common, it does happen. This is a really good reason to over-engineer the case for success. So if an implant should fail, maybe it needs to be replaced, maybe not. A lot of times if you have 6 implants and maybe just one of the middle implants or something fails, you've got 5 integrated implants. They're distributed across that bridge really well. You've got good spread and everything looks nice and solid. Of course, you definitely need to remove that implant, the problem, and get all that infected tissue out and get everything nice and sutured up. It doesn't necessarily mean that needs to be replaced. Yes, it can. Maybe it's not. And a lot of times that can even be left up to the patient. I mean, I feel pretty confident that in a bridge that has really good distribution of the implants, and there's only 5 implants, it's going to do great. They don't have to have an additional implant. It's not going to make a huge difference in the long-term preservation of that case. So a lot of times I won't replace it unless the patient wants me to, and I have no problem doing that. And, generally with Smile Now, we're packaging everything such that if these things come up, your revision is going to be virtually free unless you need some more sedation or something like that. A lot of times you don't just replace 1 implant, something we can do in like 15 minutes a lot of times. It's not a super common problem, but when it does happen, we're ready to face it. And I think something that's really important is that when you go to your doctor, again, this is another reason to have an experienced doctor, because an experienced doctor will have had lots of implant failures. If you've placed a lot of implants, you're going to have a lot of failures. You're going to go through this, and you're going to go through that troubleshooting. You're going to see how well certain things did and did not work, and have a good plan for whenever this happens. This patient says, I have had all on 4 top and bottom bridges for 12 years. Great track record, by the way. They are made out of acrylic and now starting to go thin and break, as you can see. They include a photo of a chipped tooth there. Is it possible to have the teeth replaced on top of the bridge, or do I need a totally new bridge? I'm in the UK. So this is an interesting question. So I'll start off with the material choice. So a lot of these procedures, as they were traditionally done, did restore, meaning they put the teeth on top, with acrylic teeth. So acrylic teeth are very similar to what we use for dentures. So these are basically horseshoe-shaped dentures that are being screwed into the implant. Sometimes there is a substructure there, like a metal substructure underneath that acrylic, and that's probably the case for this one if it's lasted 12 years. Not very common for someone with screwed in acrylic teeth to last 12 years without ever having a chip or breakage. So I'm assuming there's some metal underneath, and in this case, just one of those teeth is chipped. So in that particular case with the acrylic, very likely that single defect could be just repaired with additional acrylic or some bonding or something to get it back on there. Will it last a long time? Maybe so, maybe not. A lot of times with old acrylic, it becomes less bondable and it becomes very difficult to just repair it. And a lot of times you are needing to replace it. Now, the good news is replacing a bridge is very easy in general, so long as the implants are healthy and there hasn't been any bridge to the underlying implants and structure there. So in this patient's case, more than likely, yes, you could just do a quick fix, but if that didn't hold up for long, you probably just get a whole new bridge. They'll basically go in, we'll take the bridge off, we'll take new records. Nowadays with digital dentistry, this is so much easier than it ever was before, probably a lot easier than it was when he first got this done. And we take some imaging, we get everything dreamed up, and then a lot of times, we can have a zirconia or something milled within 2 or 3 weeks, and you'll have a replacement bridge, and we can do maybe like a temporary printed prosthetic on the day. So this could actually be done pretty much on the same day in one of our offices. Now, another thing to note about it is we don't typically restore anymore with acrylic with denture teeth. We're trying to set this up to last for decades. We want a really strong material, and something like zirconia is a lot less likely to be chipping in these types of situations. In situations where they do chip, yes, they are repairable. A lot of times we are replacing the entire bridge. It's really a very dynamic and patient specific thing. It depends on where the break is, how through and through it is, if it's just a chip or if it's a crack all the way through. A lot of different decision making that goes into that. And so again, just another really good reason to have a doctor that's restored a lot of these from start to finish and has maintained them over time.
Yeah. In fact, I had a patient come to me the other day, and he had an 8-year-old acrylic wrap is what we call them.
Wrap,
So it's just
yes.
like a denture over a middle bar, and the middle bar is not big. Like I've seen these be made, and it's kind of like a paper clip all the way across, right? So that guy at 12 years, this guy at 12 years, looking at his picture, like he's doing really, really well. He got his money's worth out of that because they were the best treatment, I would say, even 12 years ago for sure.
Yeah.
But today they're not, with innovations and material. What I did for that patient is when he came in, just what you said, assessed everything, decided to add 2 more implants. So he had a total of 6. And then we went ahead and made him a new set of teeth. We did it in zirconia because zirconia is a lifetime material. This is not a material that's going to like wear down. It's not like a hard plastic. It is a centered metal oxide, right? And that's what gives it the benefits of a metal while looking like a ceramic that's really beautiful, aesthetic, real natural type glow to it as far as like natural teeth go. And the reason that's a material of choice today for most full arch clinics is because the cost of it in comparison to doing a wrap, like it's very comparable nowadays. It's very comparable for the amount of time, energy, and effort put into making that into the teeth that we're talking about. So definitely time to upgrade. That's okay. Stuff gets better with time. We should embrace it. Great solution. My husband is recovering from all his teeth being extracted as well as bone grafts on his uppers and lowers, preparing for implants 6 months from now. He has temp dentures that are too painful to wear currently due to grafts and stitches. He is 5 days post-op in sheer misery, pain and lack of food and sleep since last Monday night. Smoothies are his go-tos, depression is setting in. As his spouse, it is hard to watch, and I am unable to help other that keep the smoothies and ice packs coming. Any word of wisdom from any of you that have gone through this? Okay, so yeah, my heart breaks for this patient and his spouse,
is terrible.
right?
Yeah.
I would say that today's standard of care is to not do that. Dentistry should be evidence-based. That means that we should have studies of hundreds and hundreds of cases to be able to back up why we do stuff and how we do stuff. And it used to be that this was necessary and this was totally acceptable, I would say. But today's standard of care, I don't think that doing delayed, there might be a situation in which we have to do this, right? But for the majority of people, this should not be a regular experience. There are studies that show that when you place bone into extraction sockets the day of surgery, that you get more bone in contact, meaning that when they did these studies, they actually went back, retrieved the implants. This was an animal study, but they went back, retrieved the implants, cut it out, and then they were able to measure how much bone grew and attached to the implants. And when you place implants at the time of extraction, you have more bone in contact with the implants than you do if you let it heal and then later place the implants at a later date, like what's going on right here, right? So what does that mean? Stronger implants, more bone to support it. You're going to have less issues with those implants in the future. And then in addition to that, when you do these surgeries, like a lot of these people already don't have bone. And if you smooth away some of the bone to help with this, yeah, dentures are not going to fit. They're going to be horrible. I mean, we have patients that come in all the time that have had so much bone loss from having tooth loss for years and years and years that they have no retention on a denture. A regular conventional denture does not help them in any way. And they're gluing this flat plate, like completely flat with no ridges, no flanges to like hold it in place. They're gluing it in place and it's just miserable, and they're doing it like 5-6 times a day. And that's kind of similar to what I'm hearing from this comment. So what we believe at Smile Now is that this should be a 1-day procedure, that you should have implants put in at the time of extractions, that you can do everything all at the same time. So there's one healing moment rather than multiple healing moments spread across multiple time frames, and that you should get teeth the same day. There's also studies that support that when you put teeth on implants the same day, those implants heal stronger, have more bone around them, and that overall you're going to lose less implants when you actually load them and have the Wolff's Law, right? Like where you have resistance going against them a little bit, it just causes bone to get more dense, heavier around them, and be stronger around them when you have them put them in the same day. So
Yeah, I think that, a prevailing myth in dentistry among people that aren't as familiar with full arch therapies or modern full arch therapies is that it's safer to get the teeth out first, graft, and have the patient wear a denture for some time and then come back and do this again. And truly, that couldn't be further from the truth. It just might be, maybe on the front end, it seems a lot more complex to them to get teeth out and put it in implants and give them teeth the same day. But that doesn't mean it's any better or any safer. In fact, it really is quite the opposite. So this is something that, I mean, I can't think of a time that I've had to do that where a patient didn't get teeth the same day in the past several years. And if they did, they knew well ahead of time that I was going to have to graft because there just wasn't anything to work with. But I really can't remember the last time in particular that I had to do that. And what I've seen time and time again is when a doctor is unable to get sufficient stability with the implants they place and they put them in a denture, is when that patient comes back to then have their secondary surgery to uncover those implants and then attach teeth to them, you see bone loss a lot of times because that patient's been wearing a denture and it's just been beating up against those implants, and you get less, just kind of like you were saying, you're going to get less bone in contact with those implants, and they're not going to be a whole lot worse off. And the patient was miserable the entire time because they were wearing this immediate denture that didn't have anything to be retained on top of, and they had to go through that. And it's just not a fun time, and it's not necessary anymore. For 99.9% of the population, they can get their implants in their teeth the same day. There's very rare circumstances where we can't do that, and that should never really be the plan. It's just kind of the backup plan if things don't go well, but even that should be a very rare occurrence. So yeah, again, my heart breaks for this person. This sounds like it may have been like a multiple provider issue, or maybe it was a single provider that just wasn't fully up to speed with modern things. So just know that, if you're looking at full arch therapy, the chances are 999 times out of 1,000 that you're going to be able to get teeth the same day as your implants if the doctor is, well within their capability of taking on your case.
Yeah, I would just, one more thing I would add too is I've had patients too just do dentures because the initial thought of the cost of doing implants and whatnot, because it is more expensive.
Yeah.
They were like, we just can't do that. It doesn't really work into our financial situation, which is totally fine. But after they go through an immediate denture, because that's what this person's going through. They're going through an immediate denture, right? Immediate denture is the worst procedure that I can think of in all of dentistry. Like if there's one thing that I could avoid is the misery that patients feel with an immediate denture. I mean, like imagine you walking on hot coals and your feet are just flaming and on fire, right? And then you need to go put on clogs that don't fit, clogs that like are just sizes too short, and then you have to walk 5 miles in those, right?
Yeah.
That's an immediate denture.
It is. Ugh. Yeah, no, it's the worst.
It is really difficult to get all the information, get really good information. And that's why I'm glad we're doing these segments for patients primarily, is to help them. And I hope that when they see this, if they have any specific questions, they just drop it down in the comments for us. If you want to send us x-rays, if you want to like kind of get like a second look on something, we'd be happy to put that on these segments and kind of speak to you directly if that's beneficial to you.